What if the physical sensation of feeling loose has absolutely nothing to do with your anatomy actually stretching out?
I mean, it fundamentally challenges how we think about our own bodies.
Mm.
We're so conditioned to believe that a physical sensation just directly maps to a physical geometry.
Right, like if something feels wider, it must literally measure wider.
Exactly.
Well, welcome to today's custom-tailored deep dive. We are taking you through a massive stack of medical guidelines, anatomical studies, and clinical research today.
Yeah, we've got a very specific mission today, which is decoding the pelvic floor. We're looking at how anatomy actually dictates the treatment choices for vaginal laxity.
Right. And to do that, we really have to separate the subjective feeling of laxity from the physical reality of a condition like pelvic organ prolapse.
Defining our terms is the critical first step here. In the clinical literature, vaginal laxity is strictly categorized as a symptom,
A symptom. Okay.
right? This is a subjective sensation reported by the patient. But pelvic organ prolapse, or POP, that's a structural biomechanical disorder.
So that's when things are actually physically moving out of place.
Yeah, it occurs when the supporting ligaments or the pelvic floor muscles fail, which uh, allows organs like the bladder, the rectum, or the uterus to physically herniate or bulge into the vaginal canal.
Okay, let's unpack this because the immediate assumption is that those two things are intrinsically linked,
Oh,
right?
absolutely.
If you have a feeling of looseness, you naturally assume that something has physically gotten larger or that an organ is sagging. It's kind of like feeling that a shoe is suddenly too big.
That's a great way to put it.
Yeah, like you assume the leather has stretched out, but if you actually measure your foot and then measure the shoe, they might not have changed size at all. Instead, maybe the supportive padding inside the shoe has just completely flattened out over time.
What's fascinating here is that this structural disconnect is the core of a major multi-center study we're looking at today called the Developist study.
The develop a study, right?
Yeah, the researchers wanted to see if they could mathematically correlate the symptom with the physical structure. So they had a large cohort of women complete a highly validated vaginal laxity questionnaire.
Basically to quantify exactly how loose they felt, right?
Exactly. And then the physicians stepped in to perform standardized physical measurements using the POPQ system.
And the POPQ, the pelvic organ prolapse quantification, that isn't just a casual visual check.
No, not at all.
They are essentially taking a ruler and mapping the exact coordinates of the vaginal walls relative to the hymenal ring.
Yeah, they measure everything down to the centimeter. They measure the genital hiatus, which is the physical opening itself.
Right.
They measure the perineal body, the total vaginal length, and the exact descent of the anterior and posterior walls. They're looking for hard, objective, structural data.
Which makes the conclusion of this study so fascinating to me. There was absolutely zero significant correlation between a woman's subjective feeling of laxity and her actual prolapse stage,
None. Zero.
or the size of her genital hiatus, or her total vaginal length.
And the clinical implications of that zero correlation are just massive. I mean, a patient can sit in the clinic reporting severe, distressing laxity, yet her physical measurements might be completely identical to a patient who feels absolutely normal.
Wow. So the geometry has not changed at all. The opening is not measurably larger.
Right.
But wait, are we saying the sensation isn't real? Because, that sounds dangerously close to dismissing a patient's symptoms.
Oh, no, not at all. The distress and the sensation are incredibly real.
Okay, good.
What the developed study proves is just that the physical architecture hasn't collapsed in the way the patient and, well, historically many doctors assumed it had.
Which creates a huge problem for treating it, I imagine.
A major therapeutic hurdle, yeah. If you apply a treatment designed to fix a structural prolapse to a patient whose primary issue is the sensation of laxity, you're using the wrong tool.
Right, because you can't fix a sensory symptom with a structural repair if the structure isn't actually broken. So, if the structural shoe hasn't stretched and the organs aren't necessarily falling down, what is generating this profound feeling of looseness?
Well, the research forces us to zoom past the macroscopic organs and look at the microscopic biomechanics of the tissue itself. We have to look at the cellular level.
And we're specifically focusing on two massive biological inflection points here, right? Pregnancy and menopause.
Yes. So during pregnancy and vaginal delivery, the tissue is subjected to extreme mechanical strain and distension.
Right, obviously.
But this doesn't just stretch the tissue. It triggers a profound biochemical cascade. Research shows that severe distension heavily upregulates the activity of matrix metalloproteases, or MMPs.
MMPs. And they essentially act as a demolition crew, right? Like they are enzymes that dismantle the extracellular matrix.
That's a perfect analogy.
Hey.
They cleave the proteins that hold the tissue together. This enzymatic surge physically fragments the elastic fibers embedded within the vaginal wall.
And the tissue really relies on those elastic fibers to recoil after deformation, doesn't it?
Heavily. To really understand how vital that recoil is, we can look at the animal models in the literature.
Oh, the mice study.
Yeah, researchers examined genetically modified mice that were bred without a specific protein called fibulin 5.
Fibulin 5, what does that do exactly?
It's fascinating, actually. It functions as a critical scaffold for elastin assembly. When fibroblasts secrete the raw materials for elastic fibers, fibulin 5 is the crucial protein that directs those materials.
So it tells them how to assemble correctly into functional, stretchy fibers.
Exactly.
So without fibulin 5, those knockout mice couldn't synthesize new elastic fibers at all.
Right. And the outcome wasn't just a mild change in tissue tone. When their pelvic tissue was subjected to strain, it couldn't bounce back.
Oh, wow.
And they rapidly developed catastrophic pelvic organ prolapse.
Yeah.
Their tissue just completely lost its mechanical integrity.
Because the demolition crew cleared out the old fibers, but without fibulin 5, the construction crew couldn't rebuild the scaffolding.
Precisely. That highlights the impact of sheer mechanical trauma and enzymatic degradation.
Right.
But the other side of this biological coin is hormonal. We have to look at the genitourinary syndrome of menopause, or GSM.
This is where the entire local ecosystem essentially goes into shock due to plummeting estrogen levels, right?
Yes. The surface lining, the mucosa, it thins out drastically. And that mucosal thinning sets off a chain reaction.
How so?
Well, in an estrogen-rich environment, the epithelial cells regularly shed and release glycogen. That glycogen is the primary food source for lactobacilli.
Which are the healthy bacteria that produce lactic acid and keep the vaginal pH low and protective.
Exactly. But take away the estrogen, the glycogen drops, the lactobacilli starve, the pH rises, and the surface becomes incredibly fragile.
Wow. But the real structural paradox happens below that surface layer, doesn't it? Down in the submucosa.
Down in the connective tissue, yeah. That's where you find the fibroblasts.
The biological factories that manufacture collagen and elastin.
Right. And estrogen is essentially the power grid running those factories. Post-menopause, when the power gets cut, those fibroblasts just go dormant.
So the assembly lines just stop completely.
They stop producing fresh, compliant collagen. And the existing collagen fibers undergo cross-linking.
Meaning they fuse together.
Yeah, they fuse together and become highly rigid. The tissue literally loses its physical elasticity and compliance.
So it's not just that the tissue is stretched out like an old rubber band. It's actually cellular level remodeling and enzyme activity destroying the elasticity.
Yes, that is the crucial biomechanical insight. The rigidity and lack of compliance translate neurologically as a loss of tone or a feeling of looseness.
Even though it's actually rigid.
Exactly. And it's often accompanied by significant pain during penetration because the tissues simply cannot expand anymore.
This completely flips the script on what laxity means. We assume laxity means the tissue is overly stretched and floppy.
Right.
But what we're actually describing here is tissue that has become so rigid, so fused, and so lacking in elasticity that it can no longer contour, grip, or provide dynamic support.
Exactly. So it's not a state of being too big, it's a state of being completely non-responsive, which dictates exactly how we have to treat it.
Right, because you can't do Kegels to fix the dormant fibroblast factory.
No, you can't.
And you definitely can't surgically tighten tissue that is already rigid from estrogen loss.
Treatment must isolate the exact anatomical deficit. If the issue is cellular dormancy due to GSM, the anatomy demands localized estrogen therapy to reboot the fibroblast factories and restore the mucosal thickness.
But if the physical examination reveals that the muscular hammock is the weak link, the pathway changes entirely, right?
Entirely, yeah.
Which brings us to the non-surgical interventions. Starting with the heavy emphasis in the NICE guidelines, the National Institute for Health and Care Excellence in the UK.
Yes.
Their first-line defense is rigorous pelvic floor muscle training. And to be clear for you listening, we aren't just talking about casual, unguided Kegel exercises at stoplights.
No, definitely not. We are talking about supervised progressive resistance training targeting the levator ani muscle complex.
Because the levator ani forms the primary structural hammock across the pelvic floor.
Right. When a patient undergoes a structured program, usually for a minimum of 16 weeks, The goal is true biomechanical hypertrophy.
Meaning you are physically bulking up the muscle bellies.
Exactly. By increasing the cross-sectional area of those muscles, you are physically narrowing the levator hiatus.
That's the gap the organs pass through, right?
Yes. And it provides a thicker, stronger shelf of support from underneath. Hypertrophy elevates the resting baseline tension of the pelvic floor.
So that increased support can effectively counteract early symptoms of heaviness or laxity without altering the mucosal tissue at all.
Correct. But muscle hypertrophy takes months of dedicated effort.
Which naturally leads us into the massive, heavily debated section in our sources regarding energy devices.
Oh yes, the energy devices.
Because patients are increasingly paying out of pocket for CO2 lasers and radiofrequency or RF treatments, looking for a rapid technological fix for vaginal laxity.
The mechanism of action for these devices is basically based on generating a controlled thermal injury.
By delivering heat to the mucosal and submucosal layers, right?
Yeah, the technology aims to create microdamage. The body's natural wound-healing cascade responds by increasing localized blood flow and shocking those dormant fibroblasts into producing fresh collagen.
So what does this all mean? If a patient has a torn muscle from childbirth, zapping the surface skin with a laser isn't going to fix the structural hammock, right? Or if the muscle is completely avulsed, meaning ripped directly off its attachment to the pelvic bone.
This raises an important question, and it's the exact anatomical limitation that makes these devices highly controversial for this specific application.
Are clinics basically selling a topical treatment for a profound structural failure?
Heating the mucosa does absolutely nothing to strengthen a weak levator ani muscle. And it certainly cannot reattach an avulsed muscle to the pubic bone.
It's like attempting to remodel the wallpaper while the foundation of the house is crumbling.
That's exactly it, which perfectly explains why the NICE guidelines draw such a hard line on this.
Yeah, the guidance is unequivocal. NICE explicitly states they do not recommend the routine use of energy devices for the specific claim of treating vaginal laxity.
Beyond the anatomical mismatch for muscle injuries, the clinical evidence is just incredibly limited.
Right.
Most available studies lack robust follow-up beyond 6 to 12 months. We simply do not have the data to prove that this heat-induced collagen boost provides long-lasting structural support.
So the clinical pathway demands targeted triage. A medical professional has to assess the biomechanics of the levator ani, rule out a true structural prolapse, and evaluate the tissue for estrogen deficiency before anyone should be swiping a credit card for a laser procedure.
Absolutely. Conservative management, like physiotherapy and localized hormones, can address a vast array of sensory symptoms.
But we must acknowledge the cases where this foundation truly gives way.
Yes.
When the connective tissue completely fails, leading to severe symptomatic prolapse that mimics or directly causes extreme laxity.
In those cases, the anatomy dictates a surgical route.
And surgery isn't just a one-size-fits-all tightening procedure. The entire surgical landscape is segmented by which specific anatomical compartment has actually failed.
Right. You have the anterior compartment where the bladder bulges in, causing a cystocele.
Okay.
You have the apical compartment where the top of the vagina or the uterus drops. And you have the posterior compartment where the rectum bulges forward into the vaginal space, creating a rectocele.
And the evolution of posterior compartment surgery is basically a masterclass in how a deeper understanding of anatomy revolutionizes patient outcomes.
It really is. Historically, when surgeons encountered a rectocele, they believed the solution was to manually reduce the size of the vaginal opening.
Which sounds terrifying.
They would dissect down, grab the bellies of the levator ani, specifically the pubertalis muscle, and stitch them tightly together in the midline over the rectum.
From a crude macroscopic perspective, I can kind of see the logic. If the space feels too wide and something is bulging through, you just pull the surrounding muscles together like a drawstring bag and tie it shut.
It seems logical until you test the functional biomechanics post-surgery. Stitching the puborectalis muscle together created a literal rigid speed bump of muscle across the posterior wall.
Ouch.
Yeah. This severe narrowing of the vaginal introitus resulted in notoriously high rates of dysfunction.
So it was intractable pain during sexual intercourse.
Yeah, exactly. The tissue could no longer yield or stretch.
So they successfully hid the bulge, but they completely destroyed the dynamic function of the pelvic floor. It was too tight in a fundamentally non-physiological way.
Modern anatomical mapping changed this entirely, thankfully. The surgeons recognized that a rectocele isn't usually a failure of the muscle belly itself.
It's a specific tear or attenuation in the rectovaginal fascia, right? The connective tissue sheet separating the rectum from the vagina.
Exactly. So instead of grabbing the muscle, the modern approach is a defect-specific fascial repair, or a rectisopplication.
Okay, how does that work?
The surgeon carefully dissects the tissue to locate the exact discrete tear in that connective tissue. They repair only that specific fascial defect, meticulously avoiding the puborectalis muscle entirely.
Wow.
By isolating the repair to the connective tissue, they restore the anatomical barrier holding the rectum back, while completely preserving the natural elasticity and sexual function of the muscular hammock.
It's the difference between blindly gathering up fabric and stitching it into a knot versus finding the actual tear in the seam and carefully weaving it back together.
Perfectly said.
But we also have to look at the apical compartment. Here's where it gets really interesting. There's a fascinating study in our stack about sacrococcygeal that completely challenges how we perceive surgical tightening.
Apical suspension surgery, like a sacrocolpopexy, is designed for patients whose vaginal apex or uterus is dropping down the canal.
Okay.
The surgeon uses a synthetic mesh or a biological graft to attach the top of the vagina to the anterior longitudinal ligament on the sacrum, which is the lower spine.
So they are mechanically hoisting the apex of the vagina back up into the pelvis.
Yes. And researchers decided to track exactly what this hoisting does to the surrounding anatomy using transvaginal 3D ultrasound.
And what do they find?
Well, when you perform a standard clinical exam after a sacrocolpexy, the genital hiatus, the physical opening measured from the outside, appears significantly smaller.
So clinically, it looks as though the surgery has physically tightened the pelvic floor opening.
Exactly. But the 3D ultrasound tells a completely different story.
The ultrasound allows us to measure the actual cross-sectional area of the levator hiatus internally, right?
Right. And the imaging proved that the underlying muscle gap, the levator area, did not change size at all. The muscles remained exactly the same dimensions as they were before the surgery.
It's like looking at a room with a sagging canvas ceiling. If you grab the center of that canvas and hoist it up, the tension pulls the walls inward.
Yeah.
From inside the room, the space feels tighter, the canvas feels firmer, and the doorway might even look a bit narrower. But the actual concrete foundation walls of that room haven't moved a single millimeter.
If we connect this to the bigger picture, the clinical improvements in the sensation of laxity are achieved by restoring the correct axial tension to the vaginal walls, not by anatomically shrinking the muscular opening.
That is wild.
It proves a vital point about pelvic biomechanics. You can successfully eliminate the distressing sensation of looseness and restore structural integrity without needing to aggressively or artificially tighten the underlying muscle gap.
It's entirely about putting the tension back in the correct vectors. The whole deep dive really highlights how multidimensional this issue is for you as a listener.
Absolutely.
Vaginal laxity is not just a straightforward structural stretching. It's a complex interplay of enzymatic degradation, estrogen-dependent cellular activity, and biomechanical tension.
By meticulously identifying the exact anatomical cause, whether we are dealing with hormonal tissue rigidity, elastin fragmentation, levator aneuvulsion, or a discrete fascial defect, we move away from generic tightening.
And we move toward precision medicine.
Exactly. We can leverage hypertrophy through targeted physiotherapy, we can reboot the fibroblasts with localized hormones, or we can deploy a highly specific fascial surgery.
We don't have to just throw a laser at the mucosa and hope it fixes a structural collapse.
No, we don't. But as we look toward the future of this field, there is one final, deeply provocative piece of emerging technology in the research that you should consider.
Oh, right, because we have spent this entire discussion navigating the disconnect between a patient's subjective feeling of looseness and the rigid, often inadequate clinical measurements like the POP-Q tape measure.
Right, we are still relying on a doctor's physical touch and a ruler to guess at microscopic tissue compliance.
Which seems a bit antiquated.
It is, and that is precisely what vaginal tactile imaging, or VTI, aims to disrupt. Yeah. VTI is essentially a high-resolution biomechanical mapping probe. It utilizes an array of robotic tactile sensors to measure the exact pressure, the tissue elasticity in kilopascals, and the localized muscle contraction strength of the pelvic floor in real time.
So it maps out the precise biomechanical health of every single pelvic ligament and muscle along the vaginal canal.
Consider how the entire landscape of women's health might shift when we stop relying on a subjective questionnaire about looseness or a generic physical exam.
Yeah.
Imagine utilizing robotic tactile sensors to generate a high-fidelity biomechanical map of the pelvic floor, pinpointing the exact micro tear in the fascia or the specific zone of rigid, estrogen-depleted tissue before a scalpel is ever lifted or a laser is ever fired.
We are moving toward a future where we finally get that engineering level precision for the pelvic floor. We don't have to guess if the foundation is broken. We can map it, find the exact point of failure, and treat only what is fundamentally required.
It's going to change everything.
It really is. Well, thank you for joining us on this deep dive into the true anatomy of laxity. We hope it armed you with a new understanding of the biomechanics driving your body and the hard science behind how we treat it. Until next time.